welcome. This is Dr. Mary Grady, and I'm trying to get this slideshow here started so we can talk about benign prostatic hyperplasia. So, what are we going to talk about? Well, this is a little chat about the male reproductive system, and some things here to just keep in mind while you're assessing your patient is that when any time you're in person's private area, it becomes something where you have to be respectful. There's a lot of anxiety. There might be a lot of embarrassment associated with this area, a lot of culture sensitivity, a lot of emotional issues related to sexuality and genitals. So we just have to kind of keep that in mind when we're talking with our patients and provide for their privacy. Just a little review here, a picture to kind of remind you where a few bits and pieces are here on the male reproductive. The one that I'm going to focus on right here for the purposes of this little lecture is to remind you where the prostate gland is. Prostate gland is about the size of a walnut. Whenever that starts to get enlarged as people get older, that gland starts to then press on. You can see all the different things it would press on, like the bladder. It starts to tighten around the urethra, and those are some things that would cause urinary issues. The other area we're going to focus on for the purposes of this lecture is the testes. Because of that area having an incidence or a high incidence of cancer, especially in younger males. So just kind of showing you again where the bladder is and where the prostate gland is in relation to the bladder and all of that, so it makes sense as we start to talk here. A couple of other things to keep in mind is when we think about the male anatomy, just to remember that there are some things that happen as people age, and one is that the prostate will enlarge. Most of that happens, the enlargement of the prostate, it's rare before 40. It mainly happens in more than 50% of men in their 60s have enlarged prostates with symptoms, and 90% of men in their 70s and 80s will have this, these symptoms we're about to talk about. Also, just to kind of keep in mind too, that there are some things here that removal of the testes after puberty results in shrinkage of the prostate, and these people are usually not susceptible to BPH like everyone else. Risk factors for BPH or this enlargement of the prostate gland. They have found that Black and Hispanic men develop symptoms earlier than Caucasians. A little cultural thing there. So on our assessment, what are we trying to find out? So we know how the urinary system functions, and we know that because of that, if things are not working properly, people may have increased urinary frequency. They could have decreased force of stream. So even though this prostate gland is enlarged and it's pressing on everything, the bladder and the urethra, and you're going to the bathroom a lot, you're not really going a whole lot each time you go. You're not completely emptying. And there's a decreased force of the stream when you do go. And because of this, you're having to go at nighttime. It might hurt when you go. You might see a little bit of blood in your urine, and you're just never completely emptying your bladder. These signs and symptoms that we just talked about would be related to urinary obstruction, and that's really basically what's happening with BPH is when the prostate gland gets large and it's cutting off the flow, it's obstructing urinary flow. Also on this assessment, we also not only want to ask people about their signs and symptoms, but we also want to ask things like, what medications are you on? What drugs do you take? Do you drink alcohol? What over-the-counter medications are you on? Because even though we're trying to rule out what's making all of these signs of urinary obstruction, for the purposes of this lecture, we're focusing on BPH, but it could be a lot of different reasons. So we want to really get a good picture of what's going on with that person. Also, you want to keep in mind that there are conditions that affect the function, sexual function and urinary function. And it could be like diabetes, cardiac disease, MS, a lot of these conditions, because this is a vascular area, vascular flow that's helping a lot of these things happen here. So those could all play a big part. So on our exam, we're going to exam on the male anatomy. We're going to do we're not going to do, but the physician's going to do, or an advanced nurse practitioner checking the prostate gland. But a lot of nurses and may be able to check, along with the advanced nurse practitioner and the physician, the external organs to see if we see anything that's wrong. And one of the things we would look at is the testes. And we need to encourage people to do testicular self-exams themselves. So a testicular self-exam is basically just looking around and feeling, almost like a breast exam, feeling your body, getting used to it to where you know if there's a lump or something that's not supposed to be there. Testicular exams, since testicular cancer happens so frequently in young adults, that is why this is encouraged, a very important thing to do. We have done a lot of health promotion in the high schools locally, and one of the things I did was teach the coaches how to teach the players how to do testicular exams, to talk to them about it. Because if I went in and talked to them, it'd be like your mother telling you something, and you wouldn't want to listen to me talk about it. But with the coach, that might be someone that if they tell you, it might be something that you might listen to. And we've had coaches that have talked to their players, and we've had players that have been like 16, 17 that have went home and have found areas and had to get intervention because of a self-exam. On a physical exam, you're feeling to see if there's a lump. You do this like a breast exam at least once a month so that you're getting to know whether a lump has changed or if one is just formed. Also, when we do an exam on someone's testes and we look at someone's penis, the one thing to keep in mind is if someone is not circumcised, you need to pull back the foreskin. You need to look at the head of the penis just to make sure that there's no discharge, no redness, no problems there that you can't see. But the thing about a foreskin is once you pull it back, you need to put it back how you found it, because otherwise, if you leave it retracted, it can start to like tighten on the penis and almost constrict it to the point that some people have had to have surgeries before because of people that have not pulled it back, and it caused damage to that area. So you're going to look at the testes. Now, your advanced practice nurse and your physician is going to do the digital rectal exam, and that's how they check to see if the prostate is enlarged. And if you look, because here going through the anal area, the prostate is right there. When the finger goes in to the anal area, it should feel like smooth mucosa. If you start to feel anything that's bulging in that area, it's a sign of an enlarged prostate. So examining the prostate, one of the best ways to examine it is to have someone lean over a table and then expose the person that way. Another way you could examine a prostate is if someone's not able to stand very well or to bend over very well, because remember the data that we heard about prostates, that most of this is happening in older men. So you might have someone that cannot move around very well. So you could always have them go in a sideline position, like a fetal position, because then you could access the prostate that way. Now, when somebody goes in to have their prostate checked, the best practice is it's best to draw a PSA first, a prostate-specific antigen, because once you do the digital rectal exam, it kind of stirs up and creates more PSA than you would have had before. And so it's best to get the PSA drawn, followed by the digital exam. There was a lot of controversy with this because a lot of insurance companies were not wanting to do this, and it was creating a lot of issues because people would do just the digital check and then think, well, gosh, I think the person may have an enlarged prostate, and then have to bring the person back several weeks later to do the PSA. And some of your patients may not come back. So insurance companies and health promotion, they're trying to get it to where they allow physicians to draw the PSA first, followed by the digital exam. If you think there's a problem, the physician could order an ultrasound of sonography of that area to see the enlarged prostate. When you see an enlarged prostate, you don't know if it's the benign prostatic hyperplasia that I'm talking about, or if it's cancer. You don't know what it is. Or is it just an inflammation or an infection in the area? So in some cases, fluid or tissue analysis must be done to confirm whether this is cancerous or whether this is just benign. So, a few things here to talk about. If they test it and find out it could be just inflammation because there's an infection or inflammation in that area. And in that case, they would just go ahead and give antibiotics and see if that works. The enlarged prostate, the benign, affects men over 50 and 80% of men over 80. So at some point, you're going to know someone who's got BPH. They're going to have those signs and symptoms of urinary obstruction that we talked about earlier, or retention. And because they're not emptying their bladders very well, they're going to have a high percentage of urinary tract infections. So once they do all the tests we talked about, they're going to decide whether it's cancerous or non-cancerous or an infection. And infection, they'll put you on an antibiotic. Cancer starts a whole new thing of radiation and chemotherapy. But if this is benign, and it's just that enlargement that happens as people get older, they may try pharmacological approaches first to try to bring down that swelling in that area, increase blood flow to that area. Catheterization has in some cases had to be done on these patients if they are unable to void. And a lot of times if you have someone that has to be catheterized because of BPH, there's special catheters that you can get that are curved to help go over the prostate into the bladder. Because sometimes a straight catheter is very difficult to get into these gentlemen. And there might just have to be surgery done to basically remove some of the prostate so that it's not squeezing on the urethra. So, just a little bit of information here. We already know the cells is growing, it's enlarged. And also just to kind of point out here, you worry so much about that backup of urine into the bladder or the kidneys. So another little picture. I just like pictures. And then this just kind of shows you one of the complications is the urinary reflux. Urine just kind of going all the way back up to the kidney. So you could start to have kidney problems. You could start to have bladder problems, infections galore. So we're checking these people for UTIs, and we're checking them for signs of obstruction. And this brings me to a little YouTube clip that if it'll play here. Here we go.
Hi, it's Bruce, and this is my surgery blog. Okay, for all you older guys over 50, I'm just going to get to it. In my early 50s, I had some pee problems. It was getting hard to pee, a little pressure. And I went to a urologist, and they put me on some medication. It's the prostate swells up in the middle, and it makes the urinary tract, which goes through the prostate, difficult to discharge, and so you put a lot of strain on yourself trying to urinate. So I was on a medication called Flomax, and then I changed to Cardura, which is a heart medicine, but it has side effects of lessening prostate pressure. So I was on that for about 5 years, actually. And they were recommending some surgery, and I wasn't cottoning to the fact of having surgery down there, because there's a lot of sensitive issues. So last month I had we may have some medical changes with my insurance through work, and my doctor's only on this one plan. So I didn't want to lose my urologist, so I sort of forced myself to accept the fact that maybe I should have this operation, which would be covered. So I went in. It's called a green light procedure, and it's a laser procedure. The week before a few weeks before you have to take a lot of tests to make sure you can have surgery, and the week before I had to have a test where they fill up your bladder and check the pressure of your bladder emitting, which is a very difficult test with catheters. And your bladder flow, your bladder pressure is supposed to be about 20. That's normal. 50 is a little difficult. The worst the doctor's ever seen is 144 of this bladder thing. And my score came in at 200. So they realized that I really needed this surgery. I had a couple problems with the prostate. Besides it being full, I think it was growing a little bit over. It wasn't an enlarged prostate, but they had to go in with the laser and take some of it off or something. So I was very nervous. I had to go under anesthesia, and I came out of it, and I got home, and I need a few days of recuperation. But I wanted to tell you, if you have a BPH problem and they recommend this surgery, have it. The pressure I was putting on myself, I had no concept. They said that I was like almost blowing my bladder out with the pressure that I would have to sustain to urinate. And 2 days after the surgery, I'll tell you, I feel no pressure. It's like I'm just amazed. I'm still in a little pain, and I'm on some antibiotics for after the surgery. But this green light procedure took, I guess it takes about an hour. You have to prep for an hour, and I think I was under anesthesia for about an hour. I have no recollection. I didn't even see the doctor. I saw the doctor while I was in the prep, but I didn't see the doctor enter, and I have no concept what they did to me, where they put what, and what happened. I woke up, and Bill said I was sort of babbling for a few hours under the anesthesia coming out of it. So I highly recommend this green light procedure if you're in this category. But there's different surgeries for these problems, and this surgery was for me, and it was the least invasive, and you can be back and on your feet in 3 or 4 days, tops. I think I'll be going back to work by Wednesday. So I'm a new man. I have like no pressure, and I can't tell you how happy I am. I should have had this surgery years ago. All right. I hope I helped anyone with the BPH urine flow problem. Thanks.
Okay, so the reason I showed Bert there, I really liked Bert because Bert showed us, whoops, if I can get out of here. I've got us all over the place, this technology here. Bert, what I liked about Bert is he talked about how the signs and symptoms, if you listen to him, he told you the signs and symptoms that he had for BPH. And he told you that it was very difficult for him to deal with this and how he was put on Cardura and other medications that were cardiac medications to help increase the blood flow, and how anxious he was about even having anything done in this area. And it wasn't until his insurance showed that it was going to change, that he was going to get a different doctor, that he even thought that this was even a good idea to do this. It was a change of doctor. They tested him. They found out he really didn't need to have it done, and he had laser surgery. That was the green light procedure that he kept talking about, was the laser surgery. So let's see about Bert. Bert would have had to go in, and he would have had to have a lot of testing done. He would have had to have a complete blood count to see what his H&H is, if he's bleeding, does he have like any infections with a white blood cell count up. They would look at his blood urea nitrogen and his creatinine levels. Remember, those are waste products in the body. And if those are elevated levels, that means that the kidney is not able to get those cellular byproducts out of this waste out of the body. And that would show that the body's under stress for some reason. So you would want to check to make sure that the kidneys were in good working order. The PSA, that's the prostate-specific antigen test that we had talked about earlier. And if those were elevated, that means the prostate is enlarged. He already had a digital rectal exam at some point. And when he kept talking about the pressures of his bladder, those were urinary flow rate tests and post-residual tests that they did in pressure flow studies to see exactly what was going on in the body related to this prostate being enlarged. And so then some of the medications, he was tried. They put him on medicine. He was on Cardura. He was on a cardiac med to increase blood flow. And things just weren't working. So he had a minimally invasive procedure. He had laser surgery done. And there's many different types of surgeries here that you can see. I think some of the most common ones you're going to see are laser nowadays, or the TURP, where they actually have to go in and have to do a surgery with no lasers. There's a lot of different techniques that you're going to see that they're doing now, where now they're going in and able to put stents in to help open up the ureter, different techniques to help things. Now, how they do this prostate surgery, if one has to be done, it's going to depend on how the person feels, which direction they did the surgery. Sometimes they they may have to go in through the rectal area to get it, or with the TURP, that's the most common surgical one other than lasers. They would actually just go through the penis to the prostate to get the gland. So when someone's going to have one of these done, we just know there's a lot of things we have to look at. That health history, what kind of meds you're on. Think about all the meds that would be important to know that someone's on, and how many meds would need to be stopped before surgery, especially things that increase anticoagulants, especially if I am making my clotting not as efficient as it would be normally. I'm trying to make that different. I would have to have people off of that for a while before they had surgery. What are some nursing diagnoses to think about? Well, anxiety, knowledge deficit about what's going to happen to me, and just controlling the pain pre and post-op, and infections as well. Because what are some complications of this surgery? Well, you could have an infection. So you're going to have someone that you're going to put on antibiotics before and after surgery just to prevent that. You worry about hemorrhage and shock because this is a very vascular area when you're talking about things in the rectal mucosa in that area. You worry about DVTs with this surgery. You worry about sexual dysfunction. You could go in and the surgeon could do the surgery correctly, and it could still cause damage to different parts of the reproductive area that could lead to sexual dysfunction. And when these surgeries are, after they're done, people usually have a catheter that's in for a short time to just make sure that the person's able to urinate and things are working well. And a catheter is needed because sometimes there's a lot of big clots of blood because of this vascular area. So you worry about catheter obstruction being a complication. The outcome is we just want to keep that person free of those complications and anxiety and pain. So let's deal with pain first. If we monitor the urinary catheter and keep that catheter patent, that's going to help right there. The big thing is bladder spasms create a lot of the pain. So people may be put on antispasmodics and analgesics to help with that. Warm compresses or sitz baths help relieve the spasms, especially sitz baths if they had to go in rectally to remove part of the prostate gland. Walking, you want to walk, but don't sit for long periods of time because that's like not good for that area either. You want to prevent constipation. These would be people that need to be on Colace, and just irrigate that catheter as prescribed if that catheter is starting to have lots of clots. Usually, if someone especially has the TURP version of this and not the laser, they may go home with or be in the hospital temporarily with something called a three-way catheter. And what a three-way catheter is this right here, the balloon here on this end, that goes into the patient. And it's a 30 to 45 retention balloon. That's pretty large because usually on a catheter it's a 5 or 10 milliliter if you remember from your catheter practice. So that's also, that balloon is big enough too to help kind of put some pressure in the bladder, so to help with bleeding. You have the usual bag, that's the drainage bag. But the extra you have here is you have solution that you're running into the catheter and it goes into the bladder to irrigate it. So what you have is something that looks like this. It's a three-way. The solution is going down into the patient's bladder and then coming back out into the drainage bag. Now because of that, if I irrigate that patient's bladder, this is a continuous flow going straight into their bladder. If I put 1,000 milliliters in your bladder over an 8-hour period, and you put out 1,500 in that catheter bag at the end of the 8 hours, you only put out 500 milliliters of urine, because in the case of a three-way irrigation, you have to subtract whatever fluid you irrigated the bladder with, because that's not urine, that was fluid that we put through you anyway. Also, a thing to kind of keep in mind is once someone has had a prostate surgery, they avoid rectal tubes, thermometers, enemas, anything like that for some time until the area is healed. With these continuous bladder irrigations, you just are keeping real good track of the eyes and nose, and making sure that you're watching the urine, because the urine, they want it to get to the point that it's colorless to light pink and free of clots. And just keep in mind that you want people to be urinating at least 30 milliliters of urine per an hour. And also with something like this, the other things we're looking at is a risk for hemorrhage, so we're watching. We also are teaching these people before they go home Kegel exercises to help strengthen the pelvis floor after surgery's been done in that area. And I do want to point out, because we're giving all this normal saline as a constant irrigation through the bladder, there is a risk for hyponatremia. Just the different post-catheterization care that, the basic care we would give anyone with catheterizations. And anxiety, letting this person voice their concerns, listen to them, just being sensitive, because this could be embarrassing to a lot of people. And just always be honest and explain things to people before you do them. When people go home, they're going to be told to drink a lot of water a day, 12 to 14 glasses, to help irrigate that bladder. Alcohol and spicy foods and caffeine in moderation, because they cause the bladder to be irritated. And now's not a time to have a lot of irritation going on. No strenuous activities for 2 to 3 weeks. It's going to depend on what you had done, the extent of the surgery, about how soon you could go back to work. Our buddy Bert that you listened to, he could go back to work like after a few days with the laser surgery. But for some people that had like the TURP or a more invasive surgery, it could be like a week to 2 weeks. Homegoing instruction, like I said, just telling them not to do anything strenuous. No heavy lifting or long car trips for a few months, because that puts strain and pressure on the prostate when you're in one spot for too long. A few nursing diagnoses that are listed there for people with BPH might be impaired urinary elimination, risk for infection, overflow urinary incontinence, acute pain, and knowledge deficit. There are cases when all the testing is done and they find out that it's not BPH, but it's prostatic cancer. Something to keep in mind is this is the second most common cancer in men. Early detection is key, but early detection to this or BPH is the same thing. You do the PSA testing and you do a digital rectal exam. If it is the prostate, chemo and radiation would be the course of action for this. There's another way that they're starting to work with prostatic cancer now, is they're actually starting to put little beads, radioactive beads, into the prostate. So instead of removing it or taking it out with cancer, they put these radioactive beads in there, and these beads, when placed in the prostate gland, kind of kill the cancer cells, and they have had very good luck with that. And that concludes the end of our little show here on prostatic cancer. I hope this has been interesting and that we learned something here. So I will turn this off and I will see you later. Bye-bye.